Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and today we are going to dive into another snippet. So, Maddie, can you please compare and contrast the use of external ventricular drain and intraparenchymal fiber optic pressure monitors to measure intracranial pressures?
Sure. So I think this is something that it's come up very recently in the primary exam and also for the fellowship exam, actually, but in a sort of a different context. It's important from any of this equipment perspective that we know about how they work and a bit about their advantages and disadvantages. So in terms of this, from a structural perspective, they suit the tabular format quite well. And the way I've contrasted and compared it is looking at the mechanism of measurement, the location, accuracy, calibration, damping, source of error, advantages, and something about the complications. So from a measurement perspective, for the EVDs, measure the pressure within the ventricle, and this is conducted via a fluid-filled catheter and tubing to a transducer. And the transducer uses a Wheatstone bridge, which you should hopefully be familiar with as well from the arterial line, which it converts mechanical pressure to an electrical signal by measuring changes in resistance. And therefore, that's how we measure the ventricular pressure. So this question specified intraparenchymal fiber optic pressure monitors. So the mechanism of measurement of this is fiber optic devices transmit light through a fiber optic cable to a mirror, and then changes in the pressure, so ICP changes, displace the mirror, and the differences in intensity of reflected light are then translated to a corresponding ICP value. The ICP monitors, that the intraparenchymal ones that we use at our institution, are more like a Codman's style, which aren't actually fiber optic pressure monitors. They use like a strain gauge, but it's good to know about different types of intraparenchymal pressure monitors that are available. In terms of the location of measurement, the EVDs are generally ideally placed in the anterior horn of the lateral ventricle, and that's through somewhere called Kocher's point, which is 1 to 2 centimeters anterior to the coronal suture in the mid-pupillary line. I didn't know about this, but ideally it's often they want to put it in the right side if possible, unless there's a need to put on the other side near the foramen of Monro, but it can also be inserted left-sided. And it's because it's located intraventricularly, it's thought to be more of a global representation of the overall ICP, whereas the intraparenchymal monitors, although they're inserted through the same point, or like ideally at Kocher's point, but just not as deep, so they are about 2 centimeters below the dura, and they're actually in the brain parenchyma rather than in the ventricles. They're preferably inserted in the non-dominant hemisphere, and as they sit intraparenchymally, usually in the frontal lobe, it's thought that they might sometimes be more representative of local parenchymal pressure, and that might be the case if there's any local pathology near the location where the intraparenchymal monitor is. From an accuracy point of view, EVDs are considered the gold standard of ICP measurement, so that's the standard which a lot of other newer monitors are compared to. And intraparenchymal monitors have this phenomenon called drift, which is a loss of accuracy that occurs over time. And this is especially thought to be the case after 5 days, but even after 72 hours. While this is always considered to be a problem, when they've looked at studies more recently, the magnitude of this drift phenomenon has reduced with the newer technology, and it's actually thought that the intraparenchymal monitors are quite accurate at the moment. In terms of calibration, anyone who's familiar with EVDs has seen that we can re-zero them to atmospheric pressure and we can re-level them. But intraparenchymal fiber optic pressure monitors, they're unable to be recalibrated post-insertion. So they're zeroed before they're inserted into the patient, but after that, they're unable to be changed. EVDs have damping, so they're more commonly because they're a hollow tube, they are more susceptible to things like blockages, kinks, air bubbles, whereas damping isn't really a phenomenon that's not thought to be present in the intraparenchymal monitors. From sources of error point of view, EVDs, the main ones are blockages or kinks, like we just spoke about. But because you have to be very careful with the positioning, they're leveled at a particular point. Any changes in patient positioning or bed height can result in a change in the ICP that if it's incorrectly leveled or zeroed, or if the EVD itself is incorrectly positioned. The ICP monitors, generally if they're in a good position, they're thought to be pretty accurate, except it does depend on the position of the catheter. As we talked about, it might reflect local rather than global pressure, and they are susceptible to drift. From an advantage point of view, EVDs, they have both diagnostic and therapeutic ability. So for patients with raised ICPs, we can open the EVD and drain some CSF. We can also give medications in the rare circumstances intrathecally, and we can sample CSF. So if we're looking for things like ventriculitis, they're also actually cheaper. And as we said, they are thought to be the gold standard of measuring. Intraparenchymal monitors, they can be inserted even if the ventricles are collapsed. So sometimes if you see those patients with very tight brains with collapsed ventricles, it's very hard to get an EVD in. It does require less expertise for placement, and they're unaffected by patient positioning. And because we'll go through some of the complications, but they are thought to have things like less bleeding risk and lower risk of infection compared to EVDs. From a complication risk, EVDs have higher bleeding risk. As you can imagine, they're a bigger tube, you're inserting it deeper in the brain. It's a higher infection risk because they're sitting deeper, they're within the ventricles, and it's a hollow tube that can be sampled externally. There's a greater risk of trauma during insertion. They can become blocked. They can overdrain CSF, and they can be inappropriately positioned or have an inability to insert. ICP intraparenchymal monitors do have a risk of bleeding and infection, but it's lower than EVDs, and they could be inappropriately positioned, but they're usually easier to insert. So that's a bit of a summary about EVDs versus intraparenchymal fiber optic pressure monitors. I think just have a look at them in your unit and to get a bit more of an idea about how they're used in a clinical context. And I think it'll help to consolidate some of this information.
Yeah, that's right. And I think even for fellowship exam, there has been, the question is asked around evidence, which monitor is better. And unfortunately, there is really not kind of straightforward answer to this question, which monitor is better and whether just the pure CT scan is better compared to using ICP monitoring. We all feel kind of safe with the ICP monitor in situ, but with all the caveats that you mentioned, it's not without its problem. And then the measurement error always kind of forces us to kind of do another CT brain. And often, sometimes the numbers are not accurate because, especially with the intraparenchymal monitors, where the probe lies in the injured brain, where the local pressure is high, it's not really the reflection of the global pressure. So yeah, these monitors are not without its challenges. And that's why there is no clear-cut evidence as to these monitors change outcomes.
I guess it's also hard though we don't really have evidence that any sort of monitoring changes outcomes, do we? But there's a sort of now lack of equipoise about, it's kind of standard of care. It's like from the BTF guidelines and from most hospitals within Australia that would have ICP.
That's right.
The TBIs.
No monitor can replace the good intensive care trainee. So I think we need good trainees who are knowledgeable, who are diligent, and who can replace all these monitors. So we don't need.
That's right.
Thanks, Maddie. So that's the end of our today's snippet. We'll be back with another snippet in months' time. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.